Hey everyone, welcome. I am absolutely thrilled to have you all here for this masterclass. Whether you're a resident just starting to find your footing in the wild world of regional anesthesia, or you're a seasoned attending who's looking to fine-tune your multimodal pain strategies, this explainer is designed completely for you. Today, we're talking about what I consider a true paradigm shift in postoperative pain management, the Transversus Abdominis Plane or TAP block. Now, think about abdominal surgeries for a second. For decades, controlling that post-op pain was basically synonymous with just throwing heavy doses of opioids at the patient, right? And we all know the cascade of issues that causes: nausea, ileus, delayed mobility. But the TAP block? It completely changed the game for us. It proved that by precisely depositing local anesthetic into a very specific neurovascular fascial plane, we could dramatically slash opioid consumption. We're talking about accelerating recovery, hitting those ERAS milestones, and getting our patients out of the hospital significantly faster. It's an incredibly elegant block. It's highly effective, and today we are going to deeply master the clinical evidence behind it together. Let's get into it.
Okay, let's dive into this by looking at exactly how far we've come, because the history here is actually pretty wild. We didn't just wake up one morning with these perfect, high-res ultrasound-guided techniques. Back in 2001, Dr. Rafi first described the landmark guided technique. At the time, this was a totally groundbreaking concept. It relied entirely on finding the lumbar triangle of Petit by feel to access that fascial plane. But as you can imagine, doing blind needle punctures in the abdominal wall comes with some terrifyingly significant risks. I mean, you're essentially flying blind. Fast forward just a few years to 2007, and the ultrasound-guided era officially begins. This completely revolutionized our practice. It transformed our accuracy, our understanding of the fluid spread, and most importantly, our safety profile, because we could finally see the distinct muscle layers. And now, as we look at 2023 and beyond, we're seeing this massive, rapid rise in surgeon-administered TAP blocks. These are being done under direct laparoscopic or robotic vision right there in the operating room. So it's a rapidly evolving timeline, moving steadily from blind punctures to ultrasound precision and now to collaborative surgical approaches. Here is our clinical syllabus for today. We'll start with Section 1, Anatomy and Innervation, then Section 2, Nomenclature and Classification, Section 3, Procedural Techniques, Section 4, Pharmacology and Dosing, Section 5, Clinical Evidence, and we'll wrap up with Section 6, Alternatives and Safety. All right, let's jump right into Section 1, Anatomy and Innervation. You cannot master the block without mastering the neighborhood. And this brilliantly illustrates exactly what that neighborhood looks like. When you look at the anterolateral abdominal wall and you move from the outside in, from lateral to medial, you're going to identify three very distinct muscular layers. You've got the external oblique on the outside, the internal oblique in the middle, and the transversus abdominis muscle on the inside. Notice how as you move medial to all of this, the rectus abdominis is just sitting right there inside its own sheath. Now the TAP itself, the Transversus Abdominis Plane, is literally just the fascial layer sandwiched directly between the internal oblique and the transversus abdominis. On your ultrasound screen, that dark, hypoechoic space between those two specific muscle bellies is your absolute target. Your entire goal here is to physically pry those two muscles apart with a fluid wheel of local anesthetic. You are creating a customized pocket that bathes all the sensory nerves traveling through that specific plane before they branch out to the anterior skin. It's like unzipping a lining with fluid.
So what nerves actually live in that fascial plane? Well, the anterolateral abdominal wall is supplied by the anterior primary rami of the thoracolumbar spinal nerves, running all the way from T6 down to L1. And it's super helpful to think of them as forming two distinct plexuses. First, you have the T6 to T11 intercostal nerves, which make up the upper TAP plexus. Right below that, you have the T12 subcostal nerve acting as a bit of a bridge. Then, further down, the L1 nerves, specifically the ilioinguinal and iliohypogastric nerves, form the lower TAP plexus. This lower plexus hangs out really closely with the deep circumflex iliac artery, which is a great landmark to look for. Now, here is an absolutely critical anatomical detail that you cannot forget. The lateral cutaneous branches of these nerves actually depart and pierce the muscle posterior to the mid-axillary line. Think about what that means clinically. If you inject your local anesthetic too far anteriorly, your fluid is going to miss those lateral branches entirely. And if you miss them, you will completely fail to cover any surgical incisions that extend laterally. So our bottom line for this section is this. The anatomical split between the upper and lower TAP plexuses, combined with exactly where those lateral branches depart, completely dictates where your needle needs to go.
Which brings us perfectly to Section 2, Nomenclature and Approaches. Let's clear up some of the confusing terminology out there. To keep things standardized, we generally categorize TAP locks into 4 primary approaches, and this is entirely based on which spinal nerves you are targeting. Let's walk through this table together. First up is the subcostal approach. This targets dermatomes T6 through T9, which gives you fantastic clinical coverage from the xiphoid process down through the upper abdomen. Second, we have the lateral approach. This is typically done right at the mid-axillary line, targeting T10 through T12. This is your go-to for periumbilical to infraumbilical coverage. Third is the posterior approach. By moving your probe posterior to the mid-axillary line, right near that historic triangle of Petit, you catch T9 through T12. Plus, and this is key, those essential lateral cutaneous branches we just talked about. This posterior approach is incredibly well known for providing a significantly longer duration of analgesia because the drug pools nicely in that space. Finally, there's the oblique subcostal approach. This is definitely a more advanced technique, where you actually advance your needle from the xiphoid all the way toward the iliac crest. You're trying to target that entire T6 to L1 spread for simultaneous upper and lower abdominal coverage.
But what happens if you have a patient with a massive midline incision, maybe from a major exploratory laparotomy, and you really don't want to perform that technically demanding oblique approach? Enter the dual tap block. This is a brilliant strategy. It is simply the combination of a subcostal injection and a lateral or posterior injection on the exact same side of the patient. If you do this bilaterally, we often call it a 4-quadrant block. You are actively and separately targeting both the upper and lower plexuses with distinct injections to guarantee coverage. So the absolute bottom line for naming your approaches is simple. Upper abdomen surgeries equal a subcostal approach. Lower abdomen surgeries equal a lateral or posterior approach. Always, always choose your target based directly on the surgeon's planned incision.
Moving right along to Section 3, Procedural Techniques. Let's talk about how we actually get this done in practice. Now, looking back at the historical context, the old landmark technique relied entirely on finding the lumbar triangle of Petit with your fingers and then feeling for a tactile double pop as your blunt needle passed through the tough fascia of the external and internal obliques. It sounds kind of satisfying, right? But I need to emphasize a major clinical pearl here. The landmark technique carries an incredibly high, frankly unacceptable risk of peritoneal perforation. Landmark cadaveric studies by McDermott and others have actually demonstrated visceral perforation rates up to 18%. Think about that. That is nearly a 1 in 5 chance of putting a needle into someone's bowel. For that reason alone, the blind landmark technique is completely abandoned and no longer recommended. Ultrasound guidance is the definitive gold standard, no questions asked. And beyond just making single-shot injections perfectly safe, ultrasound is what allows us to confidently place continuous catheters. When we do continuous techniques, especially via that oblique subcostal approach, we're typically using much longer 15 to 20 centimeter needles. We use them to hydrodissect the plane with a large volume, like 40 to 80 milliliters of saline or local anesthetic, before threading the catheter. This ensures the catheter sits perfectly in an open, widely dissected space. Okay, let's mentally walk through the ultrasound scanning sequence together exactly as I teach it to my residents. Step 1. You're going to start with your probe transverse, just below the xiphoid process. Find your midline, find the paired rectus abdominis missils, and spot the linea alba right in the center. Step 2. Now rotate your transducer obliquely and start sliding laterally, keeping yourself parallel to the patient's costal margin. Step 3. What you're looking for here is the aponeurosis of the linea semilunaris. That's essentially the lateral, tapering edge where the rectus muscle ends. The moment you cross that aponeurosis, boom, the oblique muscles appear. Step 4. Just continue sliding laterally out toward the mid-axillary line. Right here between the costal margin and the iliac crest, those classic 3 muscle layers, the external oblique, internal oblique, and transversus abdominis, will beautifully and clearly come into view. Your target plane is right above that deepest, innermost muscle. When you inject, you're looking for that classic, satisfying eye sign as the dark fluid creates a beautiful elliptical shape, splitting the fascia wide open.
Now, what's really interesting about this specific positioning is how it translates to the patient's body. When mapping this out for the subcostal approach, take a look at the orientation. You find the dotted line of the costal margin and the linea semilunaris. Your probe is sitting right beneath that costal margin, angled parallel to it. Your needle entry point, which we usually mark with a little X, is medial, and you advance your needle in plane, moving laterally. Your goal here is to deposit your local anesthetic in the plane just posterior to the rectus muscle, letting it extend laterally out into the Transversus Abdominis Plane. It is a really fantastic technique that gives you incredibly robust upper abdominal coverage, making it an absolute favorite for biliary surgeries like open cholecystectomies. All right, let's shift gears to Section 4, Pharmacology and Dosing, because getting the needle in the right place is only half the battle. I want you to literally burn this number into your memory. 15. This is a massive clinical pearl. 15 milliliters of local anesthetic per side is universally considered the absolute minimum effective volume for a successful TAP block. Why? Because remember, this is a volume-dependent fascial plane block. We are not blocking a single tight isolated nerve bundle like an interscalene block. We desperately need that fluid to physically dissect the fascial layers and travel widely to bathe the entire plexus. If you use less than 15, it simply won't spread far enough to be effective. In actual clinical practice, we're very often using 20 to 30 milliliters per side to guarantee that adequate dermatomal spread, while, of course, strictly keeping our calculators out to ensure we stay under our maximum weight-based toxic dosing limits.
Let's dig into the pharmacokinetics and adjuvants, because this is where you can really tailor your block. Because the TAP is a relatively avascular fascial plane, drug absorption into the systemic circulation is pretty slow. Your Tmax, the time it takes to hit peak plasma concentration, is significantly delayed. It usually hits around 10 to 35 minutes, but the literature shows it can be remarkably delayed up to 240 minutes. Now, because we are using such large volumes of drug, we always have to sweat about systemic toxicity. Adding epinephrine is highly recommended. It's a simple addition that decreases your peak plasma concentration by about 35% and delays that Tmax even further. But what about making the block last longer? Well, dexamethasone is great. It can stretch your duration by about 3 hours. Dexmedetomidine definitely improves the quality of the analgesia. But a word of warning, you must actively monitor your patients in the PACU for systemic sedation. Magnesium is an interesting one. It can impressively extend a block by up to 12 hours. And of course, we have liposomal bupivacaine, which offers the exciting potential for up to 72 hours of coverage. Now, if you are opting for continuous catheters instead of single shots or liposomes, current evidence clearly indicates that scheduling intermittent boluses every 8 hours is significantly more economical and clinically effective than just running a slow, continuous basal infusion. So, the bottom line for pharmacology: volume absolutely matters for physical spread, and smartly chosen adjuvants or bolus regimens can massively stretch your patient's pain-free window.
Next up, Section 5, Clinical Evidence and Surgical Indications. Let's look at what the data actually supports.
This table synthesizes the most current evidence-based recommendations, and I have to say, the data is getting very specific. Let's break it down. For cesarean sections, the lateral approach works really well. However, you need to know that if your patient already received intrathecal morphine during their spinal anesthetic, adding a TAP block gives little to no additional benefit. Save your time. But it is incredibly useful if intrathecal morphine was contraindicated for some reason. For cholecystectomies, the subcostal approach shows consistent superiority over lateral approaches, which just makes perfect anatomical sense given the high incision. Now, for open appendectomies, here is a clinical pearl for you. We actually have strong level 2 evidence specifically recommending posterior or lateral TAP blocks to significantly reduce pain scores. It's a highly validated indication. For hysterectomies, an anterior or lateral TAP is highly effective for open procedures, but honestly, the evidence suggests that the benefit for purely laparoscopic hysterectomies is relatively minor, assuming your other multimodal oral analgesics are optimized. Let's round this out with a few more surgical indications. For major open colorectal surgeries, good old thoracic epidurals remain the gold standard clinical priority, making TAP blocks more of a secondary, backup alternative. For prostatectomies, lateral TAP blocks are generally not recommended because they just lack proven efficacy in that specific pelvic area. And for bariatric surgeries, the benefit remains pretty unclear if you already have a really robust multi-drug ERAS protocol humming along in the background. The bottom line here is crucial. TAP block efficacy is highly, highly dependent on matching the exact surgical incision to the correct anatomical approach.
Let's bring it home with Section 6, Alternatives and Safety Protocols.
Okay, we have to talk about one of the biggest, most hotly debated topics in regional anesthesia right now: the lateral TAP versus the Quadratus lumborum or QL block. The lateral TAP is great. It provides excellent infraumbilical coverage, it's superficial, it's relatively easy, but its duration is admittedly limited. On the other hand, the QL block, where we inject much deeper near the thoracolumbar fascia, is showing some absolutely remarkable clinical data. Studies consistently indicate that the QL block reduces post-op morphine consumption by an additional 2.5 to 7.5 milligrams when compared head-to-head with the TAP block. Even better, it offers an impressive 80% longer duration of analgesia. Because of this undeniably superior profile, a lot of major academic institutions are actually starting to prioritize the QL block over the posterior TAP for their major lower abdominal surgeries. It is a fantastic, powerful alternative that you absolutely need to keep in your regional toolbox.
Another major paradigm shift we are seeing is who is actually performing the block. Historically, of course, the anesthesiologist performs it preoperatively using precise ultrasound guidance. This is brilliant for anatomical accuracy, but let's be real. It requires dedicated time in the block room, it requires nursing staff, and it can delay your OR turnover times. As an alternative, surgeon-administered top blocks are becoming increasingly standard practice. During a laparoscopy, the surgeon simply uses a transperineal approach under direct camera vision. They pass their needle straight through the peritoneum into the tap from the inside out, and they confirm correct placement by seeing a uniform fluid wheel forming on their monitor, a phenomenon known in the surgical literature as Doyle's internal bulge sign. It's actually really cool to see. This completely bypasses the entire ultrasound setup process, dramatically reducing procedural time by roughly 60 to 80%. And the best part? Studies show it provides completely equivalent analgesia with significantly fewer wrong plane injections. It is an incredibly highly efficient OR workflow alternative that we should be encouraging.
Now, regardless of who is performing the block, anesthesia or surgery, we must rigorously discuss safety. These are generally considered very safe blocks, but when complications happen, they can be severe. First and foremost is LAST, local anesthetic systemic toxicity. Because we are using such large volumes in highly vascular planes, you absolutely must calculate your maximum doses based strictly on the patient's lean body weight. Use epinephrine as an intravascular marker and a vasoconstrictor, and you must always have lipid emulsion immediately accessible in your block room or OR. Second is visceral injury. As we mentioned earlier with the terrifying McMurdo data, puncturing the bowel or the liver is an absolute disaster. This is exactly why full, continuous needle visualization under ultrasound is mandated. Let me say that again. Never, ever advance your needle if you cannot see the tip. Lastly, let's talk about transient femoral nerve palsy. The tap actually communicates with the fascia iliaca compartment anatomically. Even just 1 single milliliter of local anesthetic tracking downwards can surround the femoral nerve, leading to completely unexpected leg weakness in the PACU. It is usually completely self-limiting, but trust me, it is terrifying for the patient, the nurses, and the surgical team if you haven't warned them about it beforehand.
To maximize your safety profile and definitively prevent intraneural injection, many experts highly recommend adopting the half the air method. This is a very clever syringe compression technique where you actively monitor the injection pressure to ensure it remains below 15 psi. Think about the physics. If you are injecting freely into a wide-open fascial plane, the resistance should be incredibly low. The fluid should just flow. But if your needle tip is accidentally lodged inside a tight nerve fascicle, the pressure will rapidly spike. By utilizing this simple method, you essentially provide yourself with dual guidance. You have your visual confirmation with your ultrasound screen, and you have tactile pressure monitoring in your hand to physically prevent a catastrophic intraneural injection before it happens. So, our final safety bottom line for today, maximum safety requires absolute, uninterrupted ultrasound visualization combined with precise real-time pressure monitoring.
And with that, we have reached the end of our clinical masterclass explainer. Let me leave you with 3 core non-negotiable takeaways from today. First, your anatomical approach entirely dictates your clinical effect. You absolutely must match your specific block choice to the surgeon's exact incision. Second, the multimodal context is key. Tap blocks shine their absolute brightest when they are integrated smartly into a much larger, comprehensive pain plan. They aren't a silver bullet on their own. And third, be prepared to collaborate, because surgeon-administered intraoperative blocks are rising rapidly and establishing themselves as the new standard for OR efficiency. So I want to leave you with this final provocative thought to ponder as you head back to your hospitals and your practices tomorrow. As our ERS protocols become even more sophisticated and hyper-optimized, constantly minimizing surgical trauma and pushing for immediate early mobility, what exactly will the future role of the tap block look like? Will it eventually be largely replaced by the deeper, longer-lasting QL clock for lower abdominal procedures, or will the development of new ultra-long-acting adjuvants and slicker continuous catheter setups solidify the tap block's place as the undisputed king for the next decade? Thank you so much for joining me in this explainer. Keep reading the literature, keep optimizing your blocks, stay safe out there, and I will see you all next time.